So at the outset, I'd like to thank Dr. Madhu and the scientific committee for giving me this opportunity. Please do stop me if I'm exceeding my time. So this is a small presentation of Intacct's, our experience. So how does Intacct works? It's a crescent-shaped PMMA ring which is inserted in the corneal stroma at the depth of about 70%, and it shortens the corneal arc length, as you can see in the picture, and the central cornea flattens, and not only that, the asymmetry in the cornea is also reduced, and thicker inserts give increased flattening. So it can be combined with other procedures such as transepithelial cross-linking. It can show additive effect with cross-linking. It can also be done with Intaccts, and thereby not only stabilizing the cornea, but also making sure that some amount of refractive effect is attained by the patient. So there are two types of Intaccts, the standard one and the Intacct SK. The standard comes at 7mm optical zone, and patients with severe cases and patients who have steeper keratometry, Intacct SK is used. And it has a smaller optical zone of 6mm, and so the effect on the cornea is much better. The indications are patients who are intolerant to spectacles, contact lens wear, higher keratometric reading, staging of keratoconus is more, and patients with central corneas and a spectacle cylinder of 4.5 diopters, patients with post-LASIK ectasia. Contraindications are patients who have central scar, collagen vascular disorder, pregnant or nursing women, patients with recurrent corneal erosions and corneal dystrophies. So pre-surgical planning is whatever refraction that you get, you convert it into a positive cylinder. That is the most important thing. The positive cylinder gives you the steepest area, and then that is the area where the incision also has to go. So you have to plan looking at the topography, the pentacam, and also select the segments based on whether you're looking at a central cone or a decentered cone. And also looking at the topography, you can probably match and see whether your manifest cylinder refraction matches your topographic cylinder. And based on the cone, you can see the centered cone, you can go for symmetrical segments, and decentered cone, you go for asymmetric segments, or you can even go for a single segment depending upon the area that is need to be corrected. And the incision placement, you will have to decide based on your positive cylinder axis, as well as other verification measures such as posterior float, the pachymetry, where the thinnest pachymetry is, the amount of peripheral flattening the patient is showing. Here you can see the segment selection where you can see the asymmetric. In case of asymmetric disease, you use an asymmetric cone, as you can see in the picture, in the asymmetric picture. And the other verifiers, like I told you, was this patient has a posterior float which is very shifted very much lower down. So definitely the area of the steepest area is, and the area of the cone. So this is where you would insert the ring, and thereby the opposite area, the perpendicular area, becomes the area where the incision is made. So these are some of the nomograms which have been come along with the machine. So I'm just going to show you some cases. So this is a patient who had a minus 4.75 diopter cylinder. So we decided to place only a single segment, as you can see, that in the inferior area, and none in the superior segment and superior area. So the incision is at 45 degrees. So this cylinder is at 135. So you, when you go to the positive cylinder aspect, you get the 45 degrees as the steepest area, and that's where the incision is placed. So when you convert it, it's become minus 4.75 with plus 4.75 or 45 degrees. The incision depth is usually 70% of the area of at the 6mm. So this is just a small video showing how it is done. See, I use a femtosecond laser. There are manual methods as well. It's very simple. Hardly the procedure takes 5 to 6 minutes for me. Once the channels are made, I don't use any special instruments to open the channels. I use the Intacct itself to guide them into the channels. And the most important thing is to know the direction. First, you have to go vertically down and then go all round. If you don't go vertically down, you will create a false channel, which can actually give rise to more problems like intrusion and extrusion, etc. So this is the first post-op day. Normally, I do a sequential cross-linking. I wait for 3 days, and then I do a cross-linking. Suppose there's some residual cylinder, then I would even combine it with a topo-guided PRK in these patients. So this is one of our PG's theses, which is presented about 3-4 years back. We had 34 eyes of 31 patients who had Intacts. You can see some of them had an excellent response of in dioptric control of 6.95. So you can see the cylinder here is -6, which is dropped down to -2. The spherical from -2 to minus 0.48. So this patient had a +3 with a -7 cylinder at 155 degrees. So when you transpose it, you get the axis at 65 degrees, and this is where the incision is made. And you get, because of the cylindrical as well as the higher amount of mean spherical equivalent, you go for symmetrical rings on both sides. So you can see the ASOCT of this patient and the cross-linking effect. Again, another patient showing centralization of the cone with a drop in the Kmax from 56.7 to 50.1. This is again a patient showing an excellent response to Intacct from -9 to -2. You can see the difference map as well. This is again a patient showing a flattening by 4 diopters. So this is a pre and post-op Intacct with -7.5, have gone down to -4.5. This is again a patient who had keratoconus grade 3. And you can see the planning. I'll just go back a little. So when you plan this patient had a -4 with -7.5 cylinder. So we decided to go ahead with a symmetric segment of 0.45 at 130 degrees axis. So that is the steepest axis, and the patient showed an excellent response, as you can see here. So again, a patient with -2.25 with -4 cylinder. So the planning here was to go for an asymmetric segment, 0.4 inferiorly and 0.25 superiorly with an incision at 130 degrees. Again, the patient showed a very excellent response. As you can see, the cylinder dropped to -1.5. So this is again a patient with -5.5 to 115 degrees, and decided to go for a single segment because there was no spherical component in this patient. And this patient also pre-op and the post-op, you can see the response. So the response is often variable. We get somewhere between 50 to 70% response in most of the patients. And it depends upon the pliability of the cornea, and thinner the cornea, more pliable, we get better results. And once you get the better results, it's important that you seal it in and do a cross-linking immediately. If you wait for too long, they might have a drift. So in our patient, the average reduction in cylinder post-Intacct was about 3.75 diopters. You can see here the blue line showing the effect from -7 to -2, and this is a mean spherical equivalent. There is a slight drift over a period of few months. But when you compare it with the topo-guided PRK, you can see the significant response from pre-op -6.13, it has dropped down to 2.7. And topo-guided PRK from 2.7 to 0.75, because we do topo-guided PRK in lower cylinders, not in higher cylinders. So our results were very good. From uncorrected visual acuity improved from 0.89 to 0.61 logmar. Steep keratometric values dropped from 52 to 47. And spherical values decreased by 4.5 diopters, and cylindrical values decreased by 3.5. So Intacct is an excellent procedure from mild to moderate keratoconus. Cross-linking should be done in the same sitting or sequentially to strengthen the cornea. Thank you. So I tried to keep up my time. I hope it was not